The only entertaining part is, when I screw up, which is often. Shannon, how would you minimize aerosol producing procedures in your practice?
Okay, now I'm going to tell you right up front that right now I don't have a practice, so I'm speaking from a really hypothetical perspective. And by the way, if I had one, I'm not sure I'd be opening today. I think I'd still be kind of holding off because of those known unknowns and unknown. But that said, I got to go back to work. Okay, first thing is, you remember there's two levels of protection. We talk about engineering controls and work practice controls. All this is that, OSHA talks about that with needle recapping and all that stuff. So let's go back and let's talk about it here. Engineering control removes the hazard from the workplace. So the number one thing is to remove aerosol generating procedures and not do them at all if you can avoid it. Now, one thing I would do is I would take the Cabotron, I would unplug it and put it somewhere. So you're not even tempted to use it. I know this is a shock to a lot of people because they haven't been hand scaling for a really long time, very much. But I go back to hand scaling until we get these known unknowns and unknown unknowns resolved. Do aerosols transmit COVID-19 in the dental office? I can't say they do, I can't say they don't. I can say it's biologically plausible, and I could say based on that, I would opt for the engineering control. So I would do that. The Propy cup, and this is actually in some of the guidance, a paper that you shared with me that talks about how to manage it, and I agree with this. The Propy cup does not generate aerosols, but it does generate spatter. Right. And now that spatter, the biggest problem it causes is if you get it in your eye, and you should be wearing appropriate eye protection, that could be a problem. If you're not wearing your mask properly, and some people wear it below their nose, and it goes up your nose, you got a transmission opportunity. But the other thing is, we're going to be wearing a lot of PPE, and that PPE is going to be more expensive. CDC and OSHA both say you can reuse clinical garments or PPE if you don't generate aerosols or spatter, okay? So if you're doing a non-spatter generating procedure or a non-aerosol generating procedure, you don't have to change the garment between each patient. That's going to save you some money. So that's why I wouldn't do the Propy cups. And just explain to the patient you're doing it for their protection and your protection. And I know you love, Mrs. Jones, you love the way your teeth feel when I polish them. But we're not going to do that today. Maybe give them a toothbrush polish or something. But don't use a Propy cup. So that's on the hygiene side. Hand scaling, no ultrasonic, okay, and that's one way. Now on the operative side, when you have to use a handpiece, and this is true in oral surgery also. Oral surgery is the worst case scenario because in operative you can isolate. Now I'd say the hierarchy of isolation. I would say the dental rubber dam is still the gold standard. Now you'll read papers that say that you get more aerosol generation in the air with rubber dam because it reflects the droplets and they bounce off and they go into the air. So there's studies that show you get more aerosol. But if you've isolated saliva and there's no saliva in the field, okay, then you're going to have a safer aerosol, frankly, as long as you've managed the water. So you don't have one that's full of Pseudomonas aeruginosa and Legionella, and you don't have one that has COVID-19 in it, so it's still probably safer. So I'm going to still call the rubber dam gold standard. Now you also have devices that are used to control or create a dry field. And I'll just use the one brand name because it's been out there so long, it's almost like Kleenex, or the Isolate. But there are other products out there, and I'm not saying they're not good. So I'm not trying to endorse one over the other. But the Isolate type devices offer another opportunity and high volume evacuation. Now there's studies that show that when you properly use high volume evacuation, carefully use it, you can take care of 98% of the aerosol. There's one paper that shows this. And it's science, it's there. So maybe that works. So if you combine those things, you're getting the aerosol risk down. Are you eliminating it altogether? No, but you're greatly reducing it and making it safer. But the other option is to really carefully consider, do I need to drill on this tooth with a high-speed handpiece? Now, there's a whole set of techniques that we've often seen only relegated to Medicaid practices or to missionary work or and so forth. And that's the use of what we call atraumatic restorative techniques. And these have been pioneered. Jo Franken from the Netherlands is the guy that has been the leader in this field for many, many years. And this involves the use of adhesive cements, typically glass ionomer cements or Copomer cements, and the removal of gross caries and establishment of a clean margin in a restoration. So you're removing all the soft caries. This can be done a number of different ways, but typically it's done with either a spoon excavator, but you can also use a slow speed handpiece to remove the caries. And maybe if you have to touch up the edges, use your high speed with a rubber dam or properly isolated. You can probably use the high speed there if you're not going to pull up any saliva. But anyway, using these minimally invasive techniques when you have to drill on a tooth. Now, the other thing is in enhancing utilization of other minimally invasive services. For example, use of sealants. Sealants we use on kids, underutilized for the most part, but we do utilize them. But they work just as well on adults. If you have an adult with an incipient lesion, there's three tools in your toolkit. Number one is silver diamine fluoride, which arrests caries. You can use SDF, and then you can actually place a sealant over SDF. Because you have to rinse and dry resin sealants after you've acid etched them, I recommend not using them either, and I would go strictly to glass ionomer. Even though retention of resin sealants is better, they're equivalent in their ability to prevent caries. So a combination of SDF and glass ionomer is a great armamentarium toolkit. And you can arrest these caries, these early lesions, rather than filling them and doing that perfect little tiny early restoration and having to use a handpiece. Because you can turn patients over much more rapidly. You don't have to use PPE. You don't have to change garments between patients when you're doing these procedures. You can see a lot more patients and do a lot more of these procedures in the same amount of time as you could do traditional restorative preparation and treatment. And with your reimbursement, if you do a glass ionomer restoration with ART, it's still a tooth-colored restoration as long as you anticipate that it's going to last at least 2 years, which is the time limitation that most dental insurance companies place on a restoration. And by the way, you'll find that most of them will. It's not going to work if you're not going to be able to do custal coverage. You're not going to be able to do it. It's not going to work in the anterior because you don't get the aesthetics. But in the posterior, you can do a lot of this and still have remuneration coming in, see more patients, quite frankly, and avoid having to generate aerosols. So it's one way to consider doing it.
So Dr. Mills' dry restorative dentistry, pretty as dry as possible.
As dry as possible. And of course you want a little moisture. The nice thing about glass ionomers is they're really tolerant of a little bit of moisture. You don't want to have it too ultra dry, but you can do it. And this technique's been around for a long time, and there's good track record. And there's no reason that your insurance company would not reimburse you for doing these as an alternative to doing composites or even amalgams, which I still love, but I know they're going away. But they're still a valid and viable alternative, especially for smaller lesions. So just something to consider. Another thing you want to think about, may I continue?
Yes, please, go ahead.
Another thing you might want to consider is that when you do an aerosol procedure, that room now has a certain aerosol burden in the air. Now, if you know what the air exchanges per hour are in your room, if you're using some kind of air purifier, there's lots of things that can mitigate this. But I know that in our local hospital, in the airborne treatment rooms, when a patient leaves the airborne treatment room, they don't go back into it for another 30 minutes. They give it 30 minutes for the air to clear before they go back in. Okay? And in some cases, they can speed it up with UV lights. They can speed it up, again, other ways, or they can use one of these, electrostatic. And I'm learning more about these electrostatic disinfectant devices. I claim no expertise, but I need to get smarter about them. There's other ways to speed it up. But either way, it's time intensive. It may be cost intensive. So if you've got multiple operatories and you're going to see operative patients and be using and generating aerosols, just alternate. Try to get maybe 2 operatories and go from one to the other. Either that, or do your surgical procedure, take the next 30 minutes and do low intensity procedures in a room that's dedicated. So you have an airborne treatment room, and you have other rooms where you would never do airborne, you would never create aerosols in those, and you keep it down. And then there's one last, and that's a scheduling thing. You figure out how to make that schedule. A last thing, if you've got a multi-treatment, a multi-dentist, or a dentist and multi-hygiene operation, you may want to do shifts. And what I say by this is, you want to create teams, a dedicated team, one dentist, hygienist, whatever the number of assistants and front desk staff you need, and you work on alternate days. Because if you have one person in your office come down with COVID-19, you've got an exposure incident, and everybody in the clinic may be required by local authorities to quarantine or self-monitor, and you're shut down. But your office can stay open if you're working shifts, because say, for example, one of the shifts goes down because of an exposure or an active case of COVID-19, the other shift can actually fill that space and you can continue to see patients. You may end up working a 6-day week, but nobody's working more than 3 days. And right now, to be honest, let's all be honest, you're not going to have the volume of patients you had before. You're just not. We know that. I'm not going in. I know that. So just saying. And you have to ask yourself, are you going to go to the guy you go to? So, because do you trust them to do all the things you're going to be doing? So, I don't know.
That's good advice. I love it.
All right. They're just some thoughts. I mean, these are thought experiments on my part. I'm not running a practice. And I don't know everything you know, and I don't have to deal with the challenges you're facing out there, guys. So I'm not trying to say I'm Mr. Know-It-All and I know everything. I'm just giving ideas. And just something for you to consider as you go forward.